Hello, this is Jonathan Wick at FinThrive, and I'm giving an update on the No Surprises Act. Let's start by saying care and payment aren't equal. It's really why you're seeing such legislative and I would argue public sentiment surrounding the feelings that folks have and financial impacts surrounding bills. Healthcare often has good outcomes for folks from a clinical standpoint, but when they get the bill, it's another story. And so the No Surprises Act really came out of folks having some understanding and more importantly, I guess, protections from bills that come from third parties primarily in terms of balance billing and being surprised by those amounts as they're often out of network and reflect bill charges. I took this picture. I was at the White House about 4 or 5 years ago. That is Secretary Becerra there over the Health and Human Services. That is now Robert Kennedy Jr. Holds that position. But he said that no one should forego care out of fear for surprise billing. And health insurance should offer patients a peace of mind, and they remain committed to ensuring transparency and affordable care. And I know the Trump administration is also very committed. This is a bipartisan issue surrounding protecting consumers from bills that are, to some extent, inflated just because of the insulation surrounding an insurance contract. As I mentioned, there's a lot of pressure, and this has continued over time from consumers about coverage and cost, high deductible health plans, as more out-of-pocket shifts, legislative pressures. There's a lot of transparency, regulation, enforcement, those types of things happening now as well. Let's talk transparency for a minute. I don't think, I don't want to compare a rehab facility or a hospital necessarily to a grocery store, but nonetheless, it's a pretty opaque environment. The costs for most healthcare services are not posted, at least in a way of out of pocket. They may be posted in terms of charges. The coverage is also highly variable depending on how things are known and what's going on. As these rules come out to help kind of make that more transparent, you really got to think about what that looks like just operationally. And part of what we'll talk about today is these three rules and where we're at. They're not new. I think when I was approached to kind of put this together for you, I raised a brow a little bit because no surprise medical billing actually came out about almost 2.5 years ago. So it's pretty old, I would argue, or established legislation. Is it constantly moving? Yes, we'll certainly hear about it now. Price transparency, started out of the ACA. Enforcement really started about 4 years ago in January. There's $1 million fines. Now there's about 19 or so hospitals that have actually been kind of dinged by that first column. We'll talk about surprise medical billing today or out-of-network bills. The fine structure is not there. And then payer price transparency, or sometimes you'll hear that be called transparency and coverage, or TIC, just went into place about 2 years ago, and it's being phased into last year a little bit. You'll hear about these AEOBs, or advanced evidence of benefits, where a provider or a rehab facility or a physician or a hospital actually talk to an insurance company beforehand, all the providers, and they kind of quarterback an estimate. That's been put on hold because it's frankly too difficult to administer. Why does the act exist? Well, about 41% of insured adults are, surprised by a medical bill. 18% of those are emergency visits. That's probably the most predominant area. 21% of surgeries, 16% anesthesiology. I would argue imaging or x-ray is also in that list quite a bit. 33 states right now have enacted laws already. Hawaii is not one of them. But there aren't any balance billing protections there, but in the state statute, you might see those coming later. But this was really meant at the federal level to put in a rule where there is not a state rule in place. And equally kind of interesting is if there is a state rule in place, it actually takes precedent over the federal rule. This was really to help kind of bridge the gap between something called ERISA. There's some exemptions that surround there with tax exemptions and how insurance works and those types of things. But this was to make sure that there weren't any loopholes for folks that had ERISA plans in their states and didn't have to follow the state law. This federal law supersedes that and now takes precedent if there's in the absence of a state law. timeline here, I'm not going to go through all the details, but there are two iterations of this rule that happened in 21 and 22. Right now, the payer transparency and coverage things are getting implemented as of last year. It affects any patient who had emergency medical care. That's probably the biggest thing if you think about that with the No Surprises Act, is it's primarily focused on emergency services. That's where the spirit of it came out of. It does impact other services, but we'll go over the rule here in a minute. But basically, under any circumstance, you cannot balance bill for emergency care anymore at all. GFE, we'll talk about that in a second, but the good faith estimate has to be provided. They have to be screened for charity. If they're self-pay, if they have insurance, they have to be afforded the in-network rates and those types of things. And that's kind of the biggest deal. Air ambulance falls under that as well. Stabilization of the post-medical stabilization exam. Out-of-network services at an in-network facility must be provided at that rate, or something called reciprocity, if that makes sense. It really is two different laws. There's a protection against the bill itself, and then there's also this good faith estimate. We'll walk through each one of these, but I've kind of covered really the protection against the bill. It's that you can't bill the difference between what the insurance didn't pay, or in lack of insurance, you can't bill charges, has those things. Commercial health insurance may also not be in place for certain situations. They may only have, maybe a indemnity plan and those types of things. Regardless, in an emergency setting, you cannot bill charges to a patient anymore. That's kind of the crux of what we'll talk about today. There's also many, many rules surrounding notices, displays, postings, those types of things. A good faith estimate really is the piece that talks about the uninsured and self-pay patients, and those are required now across all service lines. They establish price transparency. They have a much larger scope, and they also have notice and display and posting rules. And at the end of this presentation, there's links to these rules. I've just kind of summarized them for you here. We're going to talk a little bit about the good faith estimate today, because I think that's where there's a lot of questions. The balance billing provision is pretty simple in my mind. You can't balance bill for emergency care anymore, or air ambulance, and even if they're out of network. But this good faith estimate's got some mechanics that are pretty complicated as we move forward. There are four big provisions within the No Surprises Act. As I mentioned, it prohibits out-of-network billing for ED, the emergency room. There's this benefit reciprocity. I mentioned that as well. For copays, coinsurance, those types of things, any out-of-pocket has to match the in-network rate for those emergency services, and for certain outpatient services as well. We'll talk through that in just a minute. And then there's no out-of-network billing on non-ED services unless something called notice and consent is provided. And then the fourth element really is this good faith estimate. So if you remember those four things, if you remember anything from this presentation, this slide is probably a good one. These are the big four things that the No Surprises Act really promulgates. Let's talk about some of the legal challenges that it came. It's been a pretty controversial type piece of legislation that's came out as we're working through it. Enforcement. So it's really kind of a low dollar, only $10,000. There's many hospitals out there that are frankly still balance billing because the penalty is not that high. And if they're getting through special case agreements or other things, the monies, they're going to do it. I think you'll see a similar path with this as we've seen in the transparency rules surrounding, an introduction of the regulation, some monitoring, and then there'll be enforcement. I think these penalties will probably go up over time. They're going to defer enforcement. They still have. I think people are still figuring out the compliance of this. There's been a lot of attention being paid to the good faith estimates. I just went out on CMS's website. They've put some more guidance out there, but there isn't anyone on a sanctions list right now, for example, or a fine that I'm aware of that has been given for someone who's violated the No Surprises Act. There's been lots of talk about the qualifying payment amounts and the independent dispute resolution process, and making sure that the amounts that are ultimately held to the provider in terms of their reimbursement and the associated out-of-pocket to the patient are, fair and qualified and usual customary rates, all that fun stuff. But there hasn't been a hospital that has balance billed someone and gotten fined and stayed that way. They've all been kind of unraveled and coached, for lack of a better word. CMS does have the complaint website up that started in 2022. I always like to point this out, that there is a portal available for patients. And so when a portal's available, more complaints will be coming. Make sure your organization is prepared to respond to said results. Texas has sued. The Texas Health Association or Medical Association sued, and they won. They're saying that this is outside the scope of CMS to establish price controls on out-of-network bills. They feel that that's a function of a contract or lack thereof, or the business that's happening between a provider and a consumer. And they won. They said that there wasn't enough information being provided to help stratify the differences in types of payments. CMS has actually added 8 elements. I believe those are in the appendix of this deck that said, hey, if you're a sole community, if you're the only hospital that does transplants, within a certain radius, if you're a rehab facility, whatever, and only have certain types of services and you're the only one, you can charge, what you want and demonstrate that. And you may in fact have amounts that are outside of those qualifying payments. A 5th District Court actually just ruled on this as late as August of last year. And they said that the government has absolutely infringed on an arbitrator's discretion to balance other factors along with these qualifying payment amounts as they choose. So I've been talking about QPAs for a while. If you don't know what those are, basically when there's a dispute between what the facility charged and what the government thinks the facility should charge based off of the rates that the payers are reimbursing and the charge masters in that area, it has to go to something called arbitration. There's a timetable and a clock there. I think I've got some information here, and we'll talk about this a little bit more later. But basically, if there's a disagreement and the payer and the hospital or the payer and the patient cannot come to an agreement on what the amount is, that qualifying payment amount is calculated based off of the metropolitan statistical area, the providers that are there, and that is set. And then they each give a bid, as weird as this sounds, the facility and the payer, the facility and the patient, and they look at the lower one and grant that. There's been a lot of discussion and things happening with this kind of baseball arbitration, it's called, as folks are looking at it. But that's what QPA is this qualifying payment amount that's based off kind of the average payments in an area, and oftentimes that's lower than what the hospitals would like. Texas won again, as I mentioned in August. They've challenged this rule 4 times. The ruling also vacated an increase of these administrative fees to get records. They kept them down at $50. The judge removed barriers for providers to file, so you can actually file claims quicker now. If you don't agree with what the QPA was, and if you want to accelerate parts of this independent dispute resolution process where it ultimately goes to that if people just can't agree on what this amount should be. CMS is also enforcing price transparency. It's quadrupled since 2000. It's just important to kind of keep that hand in hand as you're looking at it. There's 17 hospitals as of January. This list is a sanctions list. You don't want to be on this list. It isn't directly related to No Surprises Act, but nonetheless, if you're doing well in transparency, you're probably doing okay with no surprises. So you want to make sure that your patients understand what their coverage is, if any, and if they do or do not have coverage, what their out-of-pocket is, and mechanisms for them to pay for that are easy and understood, discounted if they can't afford it, and certainly discounted off of your bill charges so that you don't run into out-of-network issues. And then charity or sliding scale payment plans are offered as well. So your financial assistance policy is very important to look at as you're looking at this, and that'll pretty much keep you out of hot water with No Surprises Act as long as you're not balance billing in the ED area and you've got a good faith estimate process that's pretty good. There's some resources there in that QR code that you can go to if you have questions about transparency and other things. Enforcement of co-providers and co-facilities has been extended. It's actually still extended beyond 2025. There was this this argument that there was going to be some enforcement in 2022 about this, and hospitals and providers weren't quite ready to meet the requirements, and the government said, we understand, we released the rule, we'll give you time. I went out and looked. This rule is still in place. They haven't touched it since then. There's been some guidance that has came out, but they aren't really enforcing this rule yet. I think that's important to understand. They are providing guidance when they get a complaint to the hospitals and providers that say you did not have a good faith estimate, or you're balance billing for out of network. That's not possible, or you're well above the qualifying payment amount, and you need to go to arbitration or follow the independent dispute resolution process if you feel that you should be owed more dollars, but you're well above that, those types of things. Let's talk about this debacle that's happened with the dispute resolution. So again, this is where the facility fundamentally disagrees with the reimbursement that they're getting and feel it's too low. And so they go to the government to really challenge that as far as these on a case-by-case basis. Almost 500,000 gang disputes have came through. It's probably well over 600,000 now, if I had to guess. Way more than the government thought they would get. And there's frankly a very large backlog, and the GAO, the General Accounting Office, has been involved to kind of look at that and understand where they're at. There's a high volume of disputes. This case is nearly 14 times greater than the department initially estimated. They frankly don't have the staff to do it, and it's expending significant times of resources. So this rule was birthed. It was put out in the market, and they said, well, if you don't like how you're getting paid or the amounts, you can certainly appeal that, for lack of a better word, through the IDR, and then we'll look at it and reconsider. Well, there's 500,000 of them out there because they've all been pretty much lower. There was an outage. They were put on pause for a little while because it kind of broke the system. There were so many of these things. HHS issued some new rules. The fees went from 50 to 115 per dispute. That just because of the administrative burden. They increased the fee range to 200. Again, the Texas Medical Association has sued on some of these and won. The IDR entities will have discretion to increase fees for disputes just because of all the administrative burden to do them as well. Key components, the Congressional Budget Office also looked at some of this, and they said that what's supposed to have happened when you put the No Surprises Act out there, when it was voted on in Congress, what they said was supposed to happen, the intention of the bill was to reduce insurers' spending for out-of-network care. It was supposed to increase the spending on uncovered out-of-network services indirectly, and also reduce negotiated prices. That was supposed to have been what happened. What really happened was that the payments have actually quadrupled of Medicare. And prices have gone up. And so these decisions appear closer to the amounts insurers have historically paid. And these outcomes are reflecting that providers are submitting relatively high offers through their process and getting it. So kind of putting this in English, this was supposed to kind of curb high cost bills that were a surprise. And actually those high cost bills have stayed, but now there's just more communication around them and awareness, if that makes sense. You still can't do it in the ED, but that notice of consent can happen on the outpatient side in certain care settings, and it certainly is. This is just more data that's showing these independent dispute resolution decisions that there are well above the prior mean in-network prices. They're 500% higher in a lot of cases. And the decisions are well above Medicare rates, as well as the qualified payment amount or the average rate that's there. The offers are coming in there, and the providers are winning 70 to 80% of the time. So if you're a provider listening to this webinar, it's very important for you to, one, have a pretty solid charge master process, and please come see me if you don't. And then secondarily, you're able to defend why your prices are higher, because you win 82% of the time when you go to dispute resolution. Let's talk about some best practices for compliance. This is a really nice flow chart from the American Medical Association, and it starts up there at the top. Are you in network or not? If you are, and all your doctors are, then the contract that you have with that carrier or insurance company works, and you're done. You just go straight left to right there at the top. We wouldn't be having a webinar today if that was the case with 100% of the patients that came through your doors. So there obviously are some where your facility is not in network with the patient. My hospital followed this workflow. Then is there a single case agreement in place? That's a best practice. So anybody that comes to your hospital that's either self-pay or out of network really should be executing an SCA if you can get to it, especially on high cost things. And that just basically is a contract without it, that in the absence of one, between you and the patient instead of you and the provider, or you and the insurance company and the patient, if that makes sense. So basically says, hey, you're agreeing to come in. Here's what our fees are. Here's what you're going to pay. Sign here. Thanks. And I've got example SCAs if you need to see them, but it's not a surprise because you've both signed this contract and you know what the services there are and the patient pays. If all the providers are also covered in that, then the SCA controls as well. So, if you're doing good network flagging and know what payers are or are not in network, and you're also doing a really good job of identifying those out of network or self pays and establishing an SCA, you're not going to have that much noise with the No Surprises Act. And I see a lot of facilities, kind of stopping there, and they do a pretty good job. If all the providers are not in the network and you don't know that or have a good grasp on it, and there's just a lot of volume and it's inconsistent, that's where you start getting into the lower stratifications of this workflow. At the very top, we'll go back up there again, are all the docs there? Can they consent you? Remember, this is only for things that are not emergency. You could never, ever balance bill for emergency. But if they're coming to a rehab or they're getting an x-ray or a surgery, and you tell the patient, hey, you're coming here and we're not in your insurance company's network, you're going to pay out of network, and that shouldn't be a surprise, and you sign that, then you have a workflow for consent and notice. And then the state surprise billing laws apply, and they typically read that way. That you have to let a patient know through a waiver process. They sign that at admission, saying anything that's not covered, that's out of network or self-pay, you're responsible for, and that should be clearly outlined. Now, the rules have gotten more specific. You can't just say blanket, you got to pay for anything that happens that your place doesn't cover. You've got to be specific for this service, this date, and we'll walk through that in a minute. Over on the left side are all the docs provided. We talked about that. If they're not, can they get consent? Same workflow that you see over there in the upper right corner. So really, this workflow hinges on two things. Are the doctors and the facility all in network? If they're not, you've got to either follow an SCA or the No Surprises Act workflow, one of the two. This is another really nice workflow from Panacea. Starts with the patient on the top. I'm not going to walk all the way through it, but it basically asks those questions in those diamonds. And it'd be really good to put a policy to this in your organization. If you remember anything from this webinar besides the big four, remember this one. This is a really nice workflow to kind of pressure test whether or not you're compliant and you've got things in place. Are you asking these diamond questions? Are you documenting the answer? And are you having different actions that you could go back to on audit and show that you did what you said you did on here? And that way you kind of will stay in the good graces of the regulators and stay out of fines. Who gets a good faith estimate? For now, it's only required for uninsured and self-pay. Now, the government's looking at adding these to commercial plans. We'll see what happens. HHS defines uninsured or self-pay patients as a person who does not have benefits. So where this gets weird is something that's not covered, or they're using HIPAA high-tech and opting out of their insurance. So they may have and pay premiums for insurance, but it may not cover them. That makes a GFE apply, gangs. That's very important to know that piece. CMS has model good faith estimates on their website. You can go out and you can just Google if you want, but GFE, CMS example, and this will come up. But my advice with this is if you're creating GFEs at your organization, it better darn well look pretty close to this. If you change it, you better say why and be able to defend it, because on audit, the auditors are going to want to see this and something that looks very close to this. So I wouldn't mess with the order, the font, the shading, those types of things, unless you've got a compelling reason to do so. Things I see where folks have trouble with good faith estimates is they're not clear. They've made a form themselves. They give them out in emergency. Can't do that, gang. They're only in 2 languages. You have to follow kind of the ethnicity rules and the preferred language rules that exist under the Joint Commission and those types of things. They follow that here as well. They only cover the primary facility. They aren't looking at the extenders. So anesthesiology, pathology, radiology, all the ologies, You want to make sure you're there. It's static. You gave it out 6 weeks ago, 6 months ago, and you didn't update it. Maybe your charge master changed. Maybe the service changed. Maybe it changed when they got there. That whole workflow can get really dicey with the patient. You never sent one. It's too old. They're only supposed to be a year. You had a price increase across the board and you didn't go back. That typically will happen on ones maybe you did yesterday or a month ago. You have a price increase today across your charge master. You got to go back and do that. Not sending them out for zero charges. You absolutely have to send a GFE out, even if no money's owed. Non-traditional services count. Dental, therapies, chiro, those types of things. Changes in coverage. So scheduled it. There was coverage at the time. They don't have it now. When the service is here, time to put a GFE out in place. So very important that these good faith estimates are out there. 1031 rule is a good rule to remember for your organization. They need to go out 10 business days in advance of the appointment. And the GFE has to be sent 3 days before that. If they're not scheduled, they're a walk-in. They have to go out 3 days from the request. So they're not required, but if someone requests one, you have 72 hours from the date they requested it to turn it around. If it's 3 to 9 days in advance, you have to turn it around within a day of the request. And if they're not scheduled and it's less than 3 days, they're not required at all. Kind of confusing here. I think we'll see some more as there's monitoring enforcement, but it's a good rule to remember, this 1031 rule. Basically, 10 days out, got to get it in 3 days. If it's 3 days out, you got to get it in 1 day. And if it's less than that, you don't have to do anything. What if it's wrong? Well, patients can challenge bills if they're off by more than $400, and they could also be subject to 10,000 bills. Now, this 400 is this really arbitrary number, and it's actually very easy to be off with an estimate by that amount. I've seen some complaints come through on these, and typically the facility just does an adjustment, but just know that rule is out there. Other details with the good faith estimate is that they're really using the Health and Human Services model posting. The notice of this must be posted at all entry points and where people are scheduling. You must update it if things change, either the scope of services or the prices themselves. Recurring services can use a GFE for up to 12 months. As I mentioned, they expire. They're considered part of the medical record, gang. So they absolutely should be scanned and put into that. You must provide copies to the patients and also be able to hold them for 6 years. That's the statute of limitation in terms of your record keeping. And we're waiting on rules on whether or not they apply to insured, as I mentioned. Notice and consent requirements. Notification is for all visits. Notices must come in 15 common languages and be able to believe they receive the costs and relative network coverage and talk to what they understand and all of those things. And then consent is required for non-emergency balance billing. So good faith estimates also required. And they receive a consent to waive No Surprises Act protections because they're going to proceed. So this scenario is fairly common, but you've realized through those workflows I showed you that you've got a patient that's either walked in or on the schedule for a service that either the facility, the doctors involved, or both are not a network in that plan or they're self-pay. You have to tell that patient, you are coming in here and you do not have benefits for this. We are going to bill you the difference. You are agreeing to what that difference is. Here is what the difference is, and we'll update you if changes to that difference come. And that has a 7-year requirement. I had 6 earlier. I think 7's probably the correct one for all of these, just to be safe. But know that that's the rule. And there's a list of services CMS has on their website, but you can name one, and most of them are on there. That they've been pretty holistic with that. Let's talk convening and co-provider here for just a minute. Convening is really the quarterback. They're the one that scheduled the test or the procedure, and they have these elements on the good faith estimate that's required. They're all listed there. This co-provider part is really hard, and there's a lot of debate right now, but this is anybody else who could be involved with that service on the good faith estimate. And anesthesiology, rehab, those types of folks, pathologies, all those ologies, and you're supposed to talk to them, get that information, and put it all on one form. And if you're the one that ordered the test and scheduled it, you got to go out and hunt and gather all that. I don't see how the government's going to enforce this. but this is what the rule says as of today. So there's been a lot of talk about whether they're going to enforce it or not. But when you hear about convening and co-provider, those are what they mean. Effective the 1st of 2023, the GFE must include any item or service that is reasonably expected to be provided in conjunction by another provider facility. So like I said, the rule says any charge that's going to hit that patient, regardless whether it comes from your facility or someone else that's associated with that visit, you got to put it on there. Very difficult to comply with this, but that's what the rule says. Preparing for your independent dispute resolutions, make sure your folks are really good on their estimates. They understand coverage. Funding mechanisms are established in advance of care or at the very latest before discharge. The patient, the provider, and the payer, if there is one, are all on the same page for who's paying what and how much. Okay, very important, that first bullet. Arbitration can be expensive, so make sure you've got a budget for fighting this stuff. You saw the 70 to 80% win rate, but it's not free. There are processing fees in the hundreds of dollars for each one, and if you're doing 10 or 20 of these a month, that starts to add up. And make sure you're staying up to date. It is a novel piece of legislation. It is dynamic. I went out and looked. I hadn't seen too many changes since the last time I gave this talk, but nonetheless, feel free to keep in touch with me too. I can send updates out, or you can ask me when you're watching this, hey, has anything happened since the time you recorded it, and when we're doing, and we'll certainly move forward. 10 tips for no surprises compliance. I love this slide too. It's another important one. Make sure your staff's educated. As I mentioned early in this presentation, if you're doing a good job with transparency at your organization, estimates, charity, charge master maintenance, you can back into where somebody got a price, what they owe, and why. You should be okay with most of the No Surprises Act stuff. This is really meant to be a safety net for when you bill or an entity bills an extraordinary amount for something that really should be billed at allowed charges or and not billed. Post your model up there, update your payer directories, make sure that you know who is and out of network, both on the hospital and professional billing side. Make sure your charge master is updated at least annually. I can't tell you how many places I've seen where that's not done. And again, come see me if you have questions about that. Connect with those co-providers and see if they've got the same insurance contracts you have. And if they don't, identify the ones to where maybe you both can get to somewhere, because that'll help eliminate 99% of the problems. Verify each patient's insurance. Make sure that you're doing that every time they come in. And we had a 30-day pre-reg from history rule at my hospital. I think that's a fair rule. But after 30 days, you got to recheck again, gang. Use in-network benefits for out-of-network patients, so making sure you're following that, and that'll keep you out of trouble. Make sure that notice of consent is in place. Provide good faith estimates consistently and compliantly, and make sure you're looking at them. You might want to do a GFE audit at your organization, and how many GFEs have we sent out? If that number is 0, that's a problem. We should have some. And if they went out, were they correct? Would they have changed? Those types of things. Make sure you've got disclosure of those patient rights, and really embrace this stuff as you move forward. Some other considerations: maintain a record of in and out of network statuses for the facilities so people know. When estimates are created, the hospital must be able to notify the patient if it's out of network and obtain a record of consent for certain procedures, as I mentioned. Facility or provider must submit a copy of that to the payer as well under the AOB provisions. That's kind of an interesting rule. A lot are not doing that because there's no enforcement yet, or they say the claim is satisfying that rule. Just something interesting that's in the law. If a patient is protected under the No Surprises Act, the hospital may collect the cost-sharing amount, copays, up to the patient's in-network benefit. They can't collect the out-of-network benefit if they're not noticed and consented, or if they're in an ED setting, if that makes sense. When the hospital submits a claim that is covered, this must be noted on the claim as well. She should be able to tell the difference between claims that fall under NSA protections and ones that do not. Payers will calculate the qualifying payment amount when that's in place and provide notification to the hospital if there's disagreement. That goes to that IDR process we talked about. Defend your charge description master and your unique role as well. Other considerations for the No Surprises Act. Ensure your RCM is solid. If you're not managing your claim and collection cycle in a good way today, No Surprises Act is like gasoline on the fire. It's going to make it worse. So ensure your financial clearance. Every patient every time. You know, the funding mechanism that's going to be there, how much they're going to owe roughly, how much the payer is going to pay if there is one, and the patient knows what those amounts are and whether or not it's in network. Add as little to the process to be in compliance to. I wouldn't, boil an ocean with this stuff. Work with your payers. I know that sounds hard, but ask the payers what they're thinking about the AEOB. Find out which ones are out of network and talk to them about cases that are to come up and the best way to handle. If you've got good relationships there, those two cans in a string, that'll help out. Look for those hot spots. Make sure your provider directories are up to date. Of the docs that you have credentialing at your facility, the ones that are allowed to practice there for your medical staff, what does their insurance network matrix look like? And does that match the hospitals, and where are their mismatches? Review all your contracts. Arbitration's probably in there. Out-of-network provisions are probably in there as well. Make sure that those mechanisms are there, because remember, state law and contract law trump the federal law right now. They actually supersede it. So it's very important to look at that and understand where you're at. And then if they're in the absence of those things, then you'll have the federal law come into place. And then over-communicate this stuff. Hey, do you have questions about the No Surprises Act? Here's a flyer on the No Surprises Act. We want to make sure you're not being balanced billed for services that are out of network. Here's what that means. Make sure you have that information. But a happy and informed patient is a lot less likely to complain and just work directly with you. And you can fix it right there instead of having the government fix it for you. Ton of resources right here. I knew I threw a lot of information at you. A lot of these come from CMS. There's some from HFMA there as well. Go click on them. That first one is updated literally almost every week with new information as you look. And then there's model documents out there, as I mentioned, that talk about what the No Surprises Act is, how to be compliant, who it applies to, what type of facilities, what GFEs are required or not, the timing, all those things I kind of covered at a high level with you. They have the balanced billing notice and consent form as well. So for those services where you know that they're out of network and they're going to have a higher out of pocket, you got to give them one of these, or they can only be responsible for the in-network benefit portion, and you've got to write off the rest as a provider. So the form is here for you to use for that. And then if there's any questions, I know this might be remote or you're watching it and I'm not in the room, feel free to get a hold of me. My information's right here. It's 2 I's and a K. Jonathan.wick@finthrive.com. My cell phone number's there as well. But watch those 2 I's and a K, and you're welcome to email me and say, hey, I saw your webinar on No Surprises Act, and I don't agree with this, or I need to see that, or do you have any information there? More than happy to be a resource for you. And there's things at FinThrive that we can do for you too. That QR code also gets you to me if you need to. In the appendix is a ton of information on CMS in terms of some questions that they ask. I'll just flip through them quickly, but they ask about whether a GFE is required, what types of insurance, whether they're uninsured, what if you don't know what all the things you're going to charge, what items should be on it, what things you should do when you provide the estimate, what part of the rule under the Code of Federal Regulations is applicable, what section is applicable, how you should be giving it, all those types of things, how the IDR works, how the self-pay dispute resolution works, that $400 I talked about, how the provider resolution works, how the balance billing needs to be limited for out-of-network per statute, what that looks like in terms of what things can go to the patient or not, how people can understand what those bills look like and where you can and cannot balance bill, where consent is required, where GFEs are required, how you participate in the IDR, what that looks like, all of those bullets, and all of those other things. That is everything I had today. It was my pleasure to talk to you. And again, this is Jonathan Wick, Vice President of Health Insights at FinThrive, and I hope you enjoyed the WebEx. Have a great day. Thank you.